Good afternoon, everyone. Today's topic is intermediate uveitis and posterior uveitis. Let me share the slide for you. Okay. So, as we start with the intermediate uveitis, which is also called as pars planitis. This pars planitis is involvement of the pars plana of the ciliary body, also the peripheral choroid and peripheral retina is also involved. And that's coming to the age, second and fourth decade or usually it is involved. And both right and left side is involved, 80% of them. The 85% of them are idiopathic. The other known causes could be tuberculosis, syphilis, syphilis. It can be the other causes. Now coming to the symptoms, research those patients, they present only with a painless defective vision. There is no kind of redness, no motion irritation or other symptoms will not be there. Only they present with the just defective vision without any pain. And some people they present with the floaters, dark object floating in front of your eyes and sometimes blurring of the vision also may be compared. So this is a picture which depicts the site where the inflammation is seen. This is the pars plana of the ciliary body, peripheral choroid, and the peripheral retina. So when coming to the clinical signs, as I said, the anterior segments are minimally involved. You might present with erratic precipitation on the back of the cornea. And when they occur, you can find minor cells and flares. You know, only 1 plus or 2 plus flares and cells 1 plus. And you can have behind the lens individuals. We can have the inflammatory cells presence, and the population of these inflammatory cells forms the small balls of cotton ball opacities. And the inflammatory membranes can also be seen in the pars plana region, which we call it as a small banking. And there can be a inflammation of the peripheral vessels. So, which is the peripheral phlebitis, and the macular can become edematous, which comes to your system heading. When this is the such it is prognosis. It is when it is treated, it is 80% of them recovers well. And if it is not treated, it can lead to complications like complicated cataract. You can have cystomacular edema. And when it is burned out and the eye is no more of use because of the inflammation, then appears the damp keratopathy on the cornea. There can be an increased intraocular pressure leading to secondary glaucoma. Bleeding in the vitreous leads to vitreous hemorrhage. And because of the membrane which is formed and it is been contraction, you have a production which gets into the fractional retinal detachment happens. So, as for the treatment, inflammation, steroids are the sheet angle treatment. So, for this, topical steroids are not much help, hence, the topically applied steroids will not reach the site effectively. So, periocular steroids in the form of posterior subtenon triamcinolone is usually given. And systemic steroids is also otherwise required. And for those people who either have steroid side effects or they don't respond to steroids, and then we take the help of immunosuppressant drugs like azothioprine, methotrexate, and some these cryotherapy or direct laser photocardiogram can also be done. So when all these measures doesn't help, then pars plana vitrectomy approach will move the members. So these are all the pictures which shows the various clinical signs. So this is the first picture, which is the slit lamp picture, where you can see this lens, and behind the lens is an anterior vitreous space where you can see the vitreous cells presence. And this is the fundus picture, which shows the burnt out. Later, after the inflammation is healed, we see a periodental scar in the peripheral edge. And this is the active phase fundus picture, which shows the inflammatory membrane in the pars plana, which is called as movement. And you can see the globules of cells which is floating, and these are all the smooth ones. And this is because of the vitreous cells, there is a haziness in the vitreous. Now, as completing the intermediate uveitis, now we will come to the choroiditis. So, choroiditis, posterior choroid is where This is the area which is being involved in choroiditis. And as we see, the retina is closely associated with the choroid. Usually, choroiditis involves the adjacent retina also. Now, choroiditis, which is also the posterior uveitis, and here inflammation is either appears in the isolated foci inflammation or there may be a diffuse inflammation. This is because the nutrition of the outer layers of the retina is dependent on the choroid. So the inflammation of choroid always has the involvement of retina as well. Now coming to the etiology, how this inflammation happens, it could be an infective etiology. Either with all the either bacterial, viral, fungal, or parasitic infection can lead to posterior uveitis. Coming to the allergic side, it can be with the hypersensitivity reaction of the microbial allergy, or it can be an anaphylactic uveitis, or it can be an atopic uveitis, or the autoimmune uveitis also seen and the children's uveitis. Then toxic uveitis, and trauma can also cause traumatic uveitis. It also associated with other non-infective systemic diseases. And in malignancy, intraocular lymphoma, malignant melanoma, and leukemia, and cause the posterior uveitis. And we do also have lens-induced uveitis. Coming to the types, we have, depending on the clinical forms, presentations, we have granulomatous choroiditis, which has nodular presentation and chronic form, and non-granulomatous choroiditis, which is a doesn't have any nodular choroiditis. So as you can see, granulomatous, it is associated with organismal infection characterized by accumulation of chronic inflammatory cells like lymphocytes and plasma cells. Then you have the formation of nodules. In the non-granulomatous or exudative choroiditis, where there is a non-specific plastic inflammatory response is seen, and it is a more acute cellular withdrawal, like lymphocytes are most commonly seen, with much of the exudation is seen in the stomach. Now coming to the symptoms, so usually they come with defective vision, like in intermediate uveitis. These people presenting also doesn't have any redness or anterior segmental features. So they present with its defective vision, and they can have photopsia, which is flashes of light because of the attraction of the red photoreceptors, and they can present with cloudiness. Some of them they present with metamorphsia. So all the objects are not in the original appearance, either it has been curved. Some they present with micropsia because of the stretching of the photoreceptors. They have all the objects appear smaller. And when there is a crowding phenomena, more of the photoreceptor are concentrated in an area because of the lesions which is present, then they seems to see a micropsia. All the objects appear larger. So some after when it is filled up, you get a scar, and hence that area of the retina is no more seeing. So non-seeing area they perceive it as blind, black spots. It is photometric. So coming to the clinical signs, as we said, the eye is always quiet anteriorly. And coming to the posterior segment, where the anteriors you will have the cylinder capacities which can be seen. And in the looking dilated fundus examination, you can see active choroiditis. These active choroiditis appears as pale yellow, dirty white, raised area. These lesions appear deeper to the retinal vessels. That means the retina is not the primary tissue of inflammation. And because of the reactionary spillage of the inflammation, of the retina, which is near to the choroid inflammation, appears cloudy, and you can have the vascular, peripheral vascular near the area inflamed vascular, that is the vasculitis. So this active choroiditis are seen in the peripheral choroid, then the vision might not be of affected because they can have a floaters alone, but defective vision not usually happens in peripheral involvement of active choroiditis. But if this choroiditis involves the central posterior macula, then definitely near to the macula, definitely they will have a profound defective vision. When it means a field choroiditis, we see a well delineated area where, because of the atrophy of the choroid, you see the deepest sclera, white seen with peripheral pigment clumps the peripheries. So this is the clinical picture. Now coming to the presentation, we have a focal choroiditis. So that is, they can be a central focal choroiditis. That is, this is the central choroiditis where the defective vision will be found in them and only. And juxtapapillary. Juxtapapillary is, papillae is a optic disc, and juxtapapillary is neighboring to the disc. We have choroidal inflammation. These are the uveitis raised in the region present beneath the retina. Other, apart from this central and juxtapapillary, you do have anterior peripheral choroiditis and equatorial choroiditis. In these anterior peripheral and equatorial, the defective vision is not often found except for the pupils. Apart from the focal choroiditis, you have a multifocal choroiditis where multiple areas are being seen, and you do have a diffuse geographic choroiditis. And this is the floaters which you see, and after the healing or scar formation, that area is known same. It is photomatous area. Now, for complications, they lead to formation of cyclitic membrane or extension of the inflammation, which can be involving the anterior area also. And there can be formation of a complicated cataract, which is seen in the posterior subcapsular region usually. In the vitreous degeneration happens, we can have a diffuse macular edema. And the vessels, peripheral vessels are also involved, inflamed, and which leads to uveitis retina. And because of the membrane contraction, we have a retinal detachment as well. So this is the picture of vitreous degeneration. It's a picture of central membrane vessels. And picture of the macular edema. And these loose areas of the oxydates, which is seen. And all these presentations has to be investigated thoroughly the presence of any other additional either tuberculosis, syphilis, or HLA related, what type of uveitis is presentation, and accordingly treatment part also. The base cause for which the uveitis happens must also be treated for the treatment follow in the entire form. So only if the uveitis alone is treated with steroids, then if you don't remove the cause, then it will be recurring continuously. And after multiple recurrence, then naturally the vision will also be dropped permanently. So coming to the investigations, blood count, whether it is in acute and chronic form, represents which has been involved or which has been raised. ESR also shows the inflammatory activity. HLA-B27 for the HLA-related uveitis, and chest X-ray for tuberculosis and fibrosis involvement, and managed under etc. Treatment part, as we all said, and it's like intermediate uveitis, any inflammation, steroids is a shoot end of treatment. And the same periocular, topical is not much of use. Periocular steroid, subtenon injection. Topical also we will continue with the anterior inflammation if it is minimally also present, and topically also helping the anterior inflammation, as if there are complications, we have anterior spillover of the inflammation. Then for them, we use topical steroid. For the posterior involvement, periocular steroids works well, and systemic steroids also started along with. And in intravitreal steroids also helps fraction. This is not helping immunosuppressants are added, immunotoxic, and specific therapy because due to the tuberculosis, syphilis, toxo, in those cases, the specific treatment is also to be treated. Complication, if it is possible, accordingly, the treatment is directed to the complication which is present. So coming to few of the syndromes which is associated with the uveitis. Either it is, you can have a Reuters disease or ankylosing spondylitis, Bishop syndrome, Mucoinavi syndrome, and sympathetic arthritis. These are few much, many of them. These are only few morphologies. So coming to Reuters disease syndrome, which yes, they are present in the young males. They are associated with the HLA-B27 region. And here they have a large joints are infected and affected. And genitourinary tract they show a non-specific uveitis. And uveitis as the form is present. Posterior uveitis is also present. Anterior pillar is also seen. Coming to Behçet syndrome, here this is a serious condition with immunological basis. It also affects the young adults. They present with a severe eye hydrocephalus and myopia along with it. And they have a retinal vasculitis presentation also. So they have a presentation of oral and genital mucosa, ulcerative lesions are present with the connective tissue disorders seen. So as such, the uveitis is to be treated. No target specific area of the uveitis has to be treated as per the program. Now we have VKH, four-corneal syndrome. Here it is a bilateral condition, usually common in the Asian countries, and young adults are affected. Four-corneal reported the presence of presentation of anti-uveitis in them, and poliosis is the whitening of the eyelashes, and vitiligo, multiple patchy skin lesions, so the whitening of the skin lesions are seen, and alopecia is a non-symptom. And Harada reported presence of the posterior uveitis in them, along with the retinal detachment also seen. In the VKH syndrome, purple presence with DMT effects also, like tinnitus, vertigo, and deafness can also be the presentation. And they present with the bilateral chronic granulomatous nodules are present with the posterior synovial is seen in them. And posterior findings, they have a multifocal choroiditis, exudative retinal detachment can be seen in them, and the choroidal pigmentations are lost, and hence they see the sunset glow fungus. It's the classical presentation of the foot. Then fixed nodules can be seen, and we have a peripheral yellow-white granules. And this is a picture showing multiple some detachments, and here is the collection of the fluid and detachment. Now coming to the Fuchs uveitis syndrome. Here, Fuchs heterochromic uveitis. This is again a chronic non-granulomatous anterior uveitis present in the middle age, and these single findings of kinetic hospitals reduce stellate rate is what we call, and we have a minimal flare, 1+ of weakness can be seen. Then iris appears atrophic patches can be seen here and the mid periphery, periphery of the iris, and peculiarly the new posterior scientific formation presents in this uveitis. And there are new vessels appearance on the uveitis, which is called uveitis uveitis. And we have a complicated cataract which develops in the course. And for this, the management is in glaucoma, where there is a rise in intraocular pressure is seen in few of the cases. This is the presentation of the person with uveitis, where the eye is relatively wide. And you have here, this is the retinal photography showing multiple diffuse stellate patches, which is seen in the and we have Posner-Salzmann syndrome, which is a located psychiatric crisis. And this is the recurrent unilateral rise in the intraocular pressure, 40 to 50 milligram mercury, which is seen in the eye, recurrence, often it recurs, and there is fine decrease, there is no posterior sanity, and the corneal edema is also seen, relatively wide eye. Young adults are affected, and they have a HLA presentation of BW. They are treated with anti-glaucoma medication and steroids for the control of the uveitis. Coming to sympathetic components, there is a presentation of the bilateral granulomatous prime uveitis, and following a presentation form in which the uveal tissue is incarcerated in the non-radiated fields. Because the uveal tissues are damaged during the trauma, they are exposed to the immune system. So because of this, the traumatic eye, which is injured eye, it excites the inflammatory response, And the other eye, normal eye is also affected, which is called the sympathy. Then the presentation will be in the normal eye, you can have keratotic precipitates and not treated, you might proceed other eye as well. So how to, this is a prophylactic which we follow to prevent a eye injury or suffers, which is beyond any scope for any vision and it is badly damaged, clear tissue were exposed, then it is the part to completely manipulate the injured eye to prevent any sympathetic ophthalmitis happening in the near future. That is what is prevention follow. Now coming to pulmonary uveitis. Pulmonary uveitis, we have endophthalmitis or uveitis. Endophthalmitis is the inflammation is contained within the entire sphincter, whereas anophthalmitis, all the orbital tissues are also infected. Now coming to pulmonary uveitis, we have process separate inflammation of the as a result of direct invasion of collagen organism. And pulmonary uveitis or posterior uveitis, which progresses to the endophthalmitis and anophthalmitis. Coming to endophthalmitis, this is the involves the inflammation of the internal structure of the eye, which is choroid, retina, and vitreous. Intraocular cavities, both aqueous and vitreous also. So this is what is a picture of the endophthalmitis, where you can see discharge is present, eyelashes are limited, eyelid is swollen, and you have the delta which is congested and it is closed, and the cornea is edematous, and you have the bigger structures are hardly visible because of the corneal edema, and the eye is closed. Here, extraocular movements are restricted severely. So, what is a picture endophthalmitis, which leads to the endophthalmitis or orbital cellulitis. Now, coming to types, either it could be an infective endophthalmitis or non-infective. Etiology, how it happens, either it could be exogenous from exterior or endogenous infection can cause this. In the exogenous infection, post-operative, probably traumatic foreign body present in infected wounds and corneal ulcer. These are all from the exterior infection. And endogenous, it occurs in the immunosuppressed patients, and if there is any generalized septicemia, it is also in the metastatic infections. Now, as per the, which are the organisms which causes the endophthalmitis, we have the bacterial, positive and negative, positive, staphylococcus, staphylococcus epidermidis, Clostridium, and Bacillus cereus, and we have negatives, Pseudomonas proteus, Haemophilus, and the fungal, Aspergillus fusarium and Candida. Other functions are contaminated instruments. The non-infective, we have sterile chemicals which are added to the intraocular lens can excite a inflammatory response and retain foreign bodies, toxic reactions, intraocular tumor necrosis can happen. Like anaphylactic endophthalmitis can also happen. Those people who are at risk are diabetic mellitus, where there is an immune suppression there, and chronic renal failure, valvular disorders. Those people who have the journalist probably users and AIDS patients, immunosuppressive agents, they are all using, they are all at the risk of development of such things. And coming to the pathophysiology, how does the endogenous it is because of the penetration of the blood ocular barrier, either by the direct infection or there is a change in the muscular endothelium. Because of this, there is destruction of the intraocular tissue happens by the organism or by the inflammatory mediators. There happens to have a white nodules in the lens capsule or iris, choroid, and retina. There is inflammation, entire globe full of purulent exudates. Inflammation spreads to involve the orbital tissue. Then there happens to have a panophthalmitis. Any surgical procedure that disrupts the inflammatory of the globe, by which the exogenous infective organism can enter the eye. Now, what are the symptoms? As I said, there is a profound defective vision present, And severe pain and irritation will be there. Ocular discharge is present. Redness will be there. Ocular and periocular inflammation, so edema will obviously be there. And watering lacrimation, photophobia, they will not be able to see the light. And severe headache and vomiting is a presenting feature. So coming to the, what are the clinical signs present in them? The eyelid is edematous because of inflammation and swollen. There can be a erythema is present and the circumciliary condition is there. And the cornea, you have a hypopyon. Cornea, we have these are all the keratic receptors, inflammatory cells, which is deposited on the back of the cornea. And these cells deposits down in the because of gravity in the anterior chamber, and these are all the hypopyon. And the inflammatory cells are seen in the vitreous also, that is vitritis. And because of this inflamed vitreous, the normal red reflex is not there. Instead, you can have a yellow reflex in them. The entire eyeball is protruded out, that is proptosis is seen in them. As I said, cornea is edematous and conjunctival phimosis is also noted. Pulmonary discharge is seen in them. And when the media is, if you happen to look at the retina, you can see the white lesions in the corner on the retina. Cells are plasma perceptible at the as per the investigations, since because the visual acuity is markedly reduced, there might have a raised intraocular pressure in them. And this is the examination where you can see the hypopyon and cells inclined and pH impact. So these are the pictures representation. And fungus, this is the when you look at the inflammation of the disc, that is the capillitis, and there can have a parting spots where there is a ischemia of the neurofibrillary retina and white lesions because of the corneal inflammation you can see in the presence. So if the media is hazy, then we resort to ultrasonography. This can be done to find out the increased density of the vitreous and the thickened corneal and retinal layers. So this is the perivascularitis where you can see the inflammatory membrane seen around the vessels. In this supposed to be a normal retina with the normal vessels. The difference. Now investigations. Now blood count, total count and potential count is to check. Hemoglobin percentage and the values are blood sugar, urea, nitrogen, sodium, so as per the microbiome investigations, we to check which is the organism are we dealing with. To take a gram staining of aqueous stat can be done, or vitreous stat can be done to assess gram staining and culture sensitivity. So apart from this, the CT MRI orbit, if there is to rule out suspicion of any solution infection, then just extend to rule out the differential diagnosis. And there is any suspicion of cardiac and infective so as per this, when we present the tender thermometer, which always a emergency, to be admitted. And if there is a trauma which is structured growth, that also needs to be immediate attention. If there is any vitreous inflammation, that has to be done for a downstream culture. And by the way, the antibiotics, whichever the either if it is fungal, antifungals, they can be given in the vitreous after the so for bacterial dermatitis, topical antibiotics is known with the systemic. All the roots of antibiotic has to be examined, combined with antibiotics. With topical, systemic, intraocular is a best way to manage the endophthalmitis. So cetazolin, naproxen, inflammation in the picture, and there is raised intraocular pressure, anticoagulant measures. Given cycloplegics, we have strong anti-atropine percentage, price ranges otherwise. In intravitreal antibiotics, inflammation of amycretin, inflammation for transmitting inflammation, inflammation of inflammation, inflammation of substitution. conjunctal root either with the same, which is quite common. So conformism and dexamethasone. So this dexamethasone only in bacterial endophthalmitis after the initial cover-up antibiotics can be given and never in the cover-up endophthalmitis. Systemic antibiotics, ciprofloxacin, ceftriaxone, ceftriaxone, all this can be given orally, weekly for 15 days, subsequently for 6 to 7 days actually given. Vancomycin 1 gram only, 2 can be started. So as I said, steroid therapy for only bacterial endophthalmitis can be given with sexual infection, 4 milligram, and 1 intraocular injections, and after 24 hours only, initially it is not recognized. And coming to fungal, mifepristone and simply topical also, vancomycin is available, voriconazole is also available. Coming to surgical management, in a day or two, if there is no response, then we resort to surgical evacuation of the inflamed or infected material. To the Posterior vitrectomy is done, which is full of the cells which is infected, is removed. When there is a, and it is advised when there is only PL passage. So complications coming to you have the capsulitis and the eye can go for the diabetes. Then the vision infection can spread to orbital cellulitis, and the infection can lead to spread to the anomalous thrombosis and there is a this. Now coming to differential diagnosis, panophthalmitis, cavernous sinus thrombosis, and posterior uveitis thrombosis. Now coming to the picture of panophthalmitis, it's the inflammation of all the layers of the brain, including the inner structures, outer ocular structures, and the lens structure. So here's a picture. The setting of this is consisted with the discharge, not becoming the restricted proptosis. These are the features. Severe pain, imitation of movements. So systemic pain also, you have a raised temperature, rapid vision failure, and headache and everything. So as I said, whatever I have said, limbs are swollen, discharge is present, chemotherapy conjunctival, and white yellow reflex types of pain. Fundus examination, there will be definitely a meter will be basic and other structures will not be able to see. So we will resort to this. Coming to medical management, we do a broad spectrum antibiotics, topical steroids, and cycloplegic ectopin is given. Surgical management, either vitrectomy or evisceration can be. And coming to evisceration, here removal of the contents of the eyeball, leaving 3 millimeters of the sclera. The indications, panophthalmitis, choroidal hemorrhage, and anterior sclerosis. Separation of the contents of removal of the cornea, removal of the intraocular contents. Then you have a separation of extraocular muscles, removal of the sclera, closure of the pigment capsule and conjunctiva. So when you remove the eye, you have an empty socket, and here where you get to have the after which you can place a intraocular and you can place a shell. So this is the appearance after the shell has been placed. Thank you. That's it for today. Thank you for listening.